introduce Dr. Mustafa Raoof. Dr. Raoof is a surgical oncologist at City of Hope, here in California. He's a principal investigator for the clinical trial of PIPAC, which is something we've talked about during a lot of our Hope Zoom calls, which is pressurized intra-peritoneal aerosol chemotherapy. And we're excited to learn about the hope that this potential new treatment can give us. So with that, Dr. Raoof.
Thank you, everybody. I'm really privileged and honored that Chris invited me to talk to you about this. And certainly, it's a newer technology. It's a new kid on the block. And when it started in Europe about maybe 6-7 years ago, we were all watching it with closed eyes and see how this pans out and whether there's any truth to that. So we decided to bring it to the U.S. and kind of wanted to see how it performs in our hands. And I want to share with you some of those results from the early clinical trials that we've done. I also want to kind of frame the talk in the context of, what are the challenges and what else do we need to do to kind of, improve the outcomes for our patients. And so it'll be a little bit of, PIPAC, but I will also discuss some other things that get me excited in the morning to get to work. And other than surgery, we're always excited to do surgery. But at the same time, there are other things that are the scientists in me that they really appeal to. So with that, I want to start by just giving an overall picture that peritoneal metastases are not unique to appendix cancer, even though a lot of my patients in the clinic have appendix cancer. There are many other types of cancers where peritoneal metastases can happen, and some of the issues with a lot of these cancers are common, but there are some unique issues to appendix cancer. And so we've made a lot of progress. I think obviously we sat on the shoulders of giants, people who've done a lot of work over the years trying to improve the outcomes. And what we've learned is that in general, this is a very aggressive problem. There's a spectrum, there's heterogeneity, there's a lot of different outcomes that people can have, but for some folks this can be really aggressive. And there are unique quality of life considerations. We heard the earlier talk. And honestly, we're not doing a great job at measuring quality of life routinely across centers. I think there's some centers that are doing a really phenomenal job, but then most centers are not measuring quality of life as an outcome. So there are those considerations that get ignored or not measured, and we don't hear about them. Till the patients are not doing well after a long time. And we've learned that cytoreductive surgery has improved survival for many of the cancers, including appendix cancer. And we talked about morbidity and mortality has gone down over the last 10, 20 years. And a lot of it has to do with better patient selection. Our techniques have improved. We have figured out what things are the major determinants of poor outcomes after surgery. And so a lot of that has improved. And so, how do we make it so that this is even better? How do we make sure that we reduce the complication rates? You saw Dr. Baumgartner's slide. Most people will have some sort of complication. 60% of patients will have some sort of complications after surgery. 20% will still have major complication, which is some sort of procedure that is needed after surgery, either a trip back to the operating room, a trip to the ICU, being on a ventilator. Those can be quite catastrophic. It can put you out of commission. You may not be eligible to get further chemotherapy. So there's a big room for improvement there. And I think ERAS is really great at standardizing treatment across centers, but we also have to start thinking about personalizing perioperative care. So not one person is similar to another person. So we have to think about unique considerations a person brings as they're going into surgery. And so can we use artificial intelligence? Can we use machine learning to help us see the picture in the data that our eyes cannot see and help us decide what are the factors we should be focusing on and take the guesswork out of them? you know. And so experienced surgeons will have their gestalt, they will have their intuition, but that takes 30, 40 years to develop. And so a lot of the workforce that is doing PIPAC is relatively young in their experience. So everybody should be able to get some sort of benefit from that experience through a standardized set of assisting tools, if you will. So this is where machine learning could be helpful. So we looked at this data from the US PIPAC Collaborative, which is a collaborative of 12 institutions, and we applied machine learning to it. And you know, the machine learning algorithm can give us some global predictors of what are the things that can increase the risk of complications. So this is, you know, it kind of validates what has been published in the literature. So this is exciting, but it's not as exciting. But when you dig deeper into the data, the data will show you some clusters of patients. So you can group different risk levels for patients into different clusters and say, okay, this person who's walking through the door in the clinic can be put into, you know, this sort of a somewhat personalized, standardized pathway. So we can get more, we can fine-tune our EVAS pathways so that, you know, we can specifically address the needs of that patient. And so we're just starting to get into that a little bit. And these clusters vary significantly in their risk of complication. Some of those factors are surgical, some of those are from blood loss, some of those are inherent, general deconditioning and things like that. So the idea is that, you know, when you are talking to your surgeon, you get a scorecard and you say, okay, these are my risk factors. The blue factors are the ones that reduce the risk of complication. The red factors are the ones that increase the risk of complication. So if you look at panel C, you know, what are the factors that are increasing my risk of complication from the surgery? What are the factors that are reducing? And not only that, how much is that each factor contributing? And more importantly, if it is a modifiable factor, we would like to modify that before surgery. You know, if the time allows, we can do specific targeted rehabilitation. So I think this is where the field is moving. We're very excited to kind of see the transition. And so right now, the big challenge here is to integrate this into our electronic medical record so that it's not a huge task load on clinical team to input all the information to get the result for that patient. So, you know, that's just an example of the successes we've had, but there are multiple challenges that remain. Many of the patients, as you're well familiar, are not candidates for cytoreductive surgery. In fact, 20% or so patients will be candidates for cytoreductive surgery. Either biologically their disease is too aggressive, or the extent of disease is too much, and you know, surgery may not be the best option. Especially for high-grade appendix cancer, you know, we know that 80% of patients will have a relapse after surgery. Many of them will have it within a year. So, you know, you're doing this major operation, whereas 20% of patients will kind of make it to 5 years. So it is you know, those odds are not really exciting. So we have to make some improvement in that realm. We know that systemic therapies, you know, there's this craze about immunotherapy. Unfortunately, you know, appendix cancer patients have not really benefited from this explosion of immunotherapeutics. We're not there yet. I think there will be opportunity for that. We haven't made enough progress yet on that, so I think there's room there. Anytime we're talking about complete resection, we always have a trade-off. You know, we're always thinking about the longevity, but we're also taking away quality of life. And these are discussions many of you had with your doctors in the clinic, and these are the tough discussions because there's no objective data to guide you what that quality of life will look like and what that longevity will be exactly after the surgery. So we have to get better at that. And then regional therapies, which PIPAC is a component of, has shown promise, but you know, we're looking to develop some high quality evidence. And a big part of it is, I think, just to follow the theme with other cancer types. We've now known for a few years that appendix cancer is very heterogeneous. It's very different from one person to another. And we have to figure out what it is that is different and then personalize the treatment to that difference. So how do I see the future of peritoneal surface malignancies, appendix cancer being the poster child of that? we need personalization at the top, and static personalization tools are like genomic sequencing, things you draw one time, and then you look at it and say, okay, this is your genomic profile, this is the therapy for you. We've been doing sequencing for a long time. We haven't been successful in matching mutations to therapy. There's hope there. There are rare occasions where a certain mutation happens and we can give therapy directly against it and we see success. But for the most part, we haven't seen that success. But there's a newer area of doing some dynamic modeling, taking the patient's tumor, growing it in the lab, and testing multitude of therapies, and then figuring out what is the right drug for that patient. So I think that we're going to see a lot more of that over the next 5-10 years. That's going to hopefully improve the overall therapy. There are novel therapies that are being developed for different types of cancers, but if we have preclinical disease models, we can repurpose those therapies to use for appendix cancer. And so I think the organoid platforms go hand in hand with development of novel therapies. So the big roadblock is right now to develop those preclinical dynamic models. And then we're making a lot of progress in terms of enhanced drug delivery platforms that go beyond just cytoreductive surgery and PIPAC. So with that, what is PIPAC? So this is a graphic, a cartoon graphic of what PIPAC looks like. So it is a cross-section of the abdomen. This is typically how laparoscopy is performed. So there are two, for those of you who have laparoscopy will know that there are 2 ports or 3, or sometimes more, little tiny instruments. They're kind of shown out of proportion for better visualization, but they're typically a diameter of this is about 5 to 10 millimeters, and these are placed in the abdominal cavity. And it is connected on one end to a nebulizer. You can see on the screen right. The nebulizer sits in the trocar, and on the back end it is connected to a pressurized injector that kind of fumigates the chemotherapy into the abdomen under pressure. And these ports are initially placed as working ports where you can take biopsies, put in a camera, take a look around, assess the disease burden, and after that, once that is done, the chemotherapy is infused or the abdomen is fumigated, and then this is a repeatable process. It's minimally invasive. Majority of our patients stay overnight and go home the next day. It makes sense because you're directing therapy directly to the sites of tumors that could be the most threatening, for example, on the small intestine. There are theoretical benefits that have been shown in some of the models in sort of animal studies and ex vivo models where you can get higher chemotherapy delivered directly into the tumor. Because it is an outpatient procedure and it is repeatable, patients can go about their quality of life. The first week after that is usually rough. And I will talk a little bit more about our initial experience with the PIPAC only trial. But in between those, the next 5 weeks, a lot of people recover and they're able to do a lot of things that they wouldn't otherwise be doing on just systemic therapy. From Europe, this is what caught our eye when we got interested. And in 2019, they published experience from European centers, and they said that for a variety of cancers, appendix cancer is not listed one of them, but the benefit to patients was somewhere between 60 to 80%. And to us, that was kind of out of the ordinary. Usually you expect most systemic therapies, you expect a response in the first line, meaning shrinkage of tumor in the order of 15 to 20%. So something like that was totally different. And then the adverse events were very low. So systemic therapies, the first line systemic therapy, the severe adverse event rate is about 30%. So to have it something like 12 to 15% was actually very interesting. So these are some of the earlier, this is a big model. So you can see there's, in this big model, you can see the big intestines. There's some PIPAC on one side and PIPAC on the other. And you can immediately see with the PIPAC, there's more blue that kind of stays in the abdomen. So suggesting that perhaps there's more treatment that is staying in the abdomen. And that was one of the initial proof of concept studies. It has taken on in Europe. You can see on the screen right, there's a lot of trials, but none of them are in the US. These are phase 2, phase 3 trials that are ongoing. And to be honest, the United States has lagged behind in the take-up of PIPAC because everybody was very skeptical of this technology. And because it had moved to phase 2 and phase 3 trials, and there were some, in reputable journals, there were some encouraging reports we wanted to see what it looks like in our hands. So with that, we started a phase 1 trial at City of Hope, and this initial trial had 2 arms. There was an arm 1 and arm 2. Arm 1 was ovarian and uterine cancer. This is with my co-principal investigator, Dr. Dellinger, who runs arm 1 of the study. And then arm 2 was focused on colorectal cancer initially, but we added appendix cancer to it. And this is patients who are chemotherapy refractory. They've had, they've done their full FOX, they've done their full FELI, and they're looking for trial treatments. And almost all of the patients had had 2 lines of therapy before. And in this case, we were offering PIPAC every 6 weeks. And the first PIPAC was just oxaliplatin PIPAC. And the second and third PIPAC, we gave a small dose of 5-FU bolus before the PIPAC as a sensitizing agent. So it's been known for many years that when 5-FU chemotherapy is combined with oxaliplatin, it works better. So we wanted to keep that in the trial. With the first PIPAC, we eliminated that because we wanted to assess the toxicity of PIPAC alone. And so arm 2 is completed accrual. Arm 1 is enrolling, but I think we have all the patients for the trial. I think it will close very soon. And so this is a partnership with 3 sites. You can see City of Hope on the West Coast, Northwell, Northeast, and Mayo Clinic Jacksonville, Southeast. This is kind of the setup what the injector looks like. On the right side, you can see there's chemotherapy with 2 syringes, and on the left side, sorry, on the right side, you can see the view of the injector that is seen by the surgeon as they're administering the chemotherapy. This is what the nebulizer looks like, or aerosolizer looks like. It's basically high flow, and then there's a resistance mechanism. With that, an aerosol is generated. So this is very typical of other nebulizers that are out there. There's some special considerations here that make the size of the aerosol more optimal for delivery into the peritoneum. So this has been engineered in Germany, and there's been a lot of studies that look at the optimal size of the aerosol. So when we start the operation, we start with the laparoscopy. On the top left of the screen, you can see there's a camera. We put in ports. First step is to do the assessment. We look at the burden of disease in the abdominal cavity. We store it. There's the PCI scoring sheet. There are other scoring that we do as well. And then we video record all of that so that in the future, if we can develop better ways to assess disease burden, we can do that. We take biopsies in 4 different quadrants of the abdomen. We don't take biopsies on the bowel or viscera because in the past in Europe, when they've done that, they've had higher risk of complications. So it is actually not recommended to take biopsies on the small intestine itself. Sometimes we've done biopsies on the mesentery, which is a lot safer to do. Once that is done, you can see we use balloon trocars so that the aerosol doesn't escape outside the abdominal cavity. This is to protect the staff in the operating room. And you can see the nebulizer kind of sitting in the trocar in the bottom picture over there. And once that is done, this is kind of the setup in the operating room. You can see an anesthesiologist through the glass window over there. They're wearing their protective gear. They're standing outside. Everybody leaves the room. The monitors turn to that side, so we're monitoring. The anesthesiologist is monitoring the patient remotely. There's an IV line, which is very faint on this picture, but you can kind of see over here. It runs underneath the door, and they're remotely administering drugs and monitoring. But everybody's prepared to come back in if there's any issue, on the monitors and everything, so they're ready to go. And so then after that, we remotely activated, and it looks like like a snowstorm in the abdominal cavity. You can see the aerosolizer sprays, the chemotherapy. So
What's the scale of that photo? How small is this thing?
this aerosolizer is about 10 millimeters. So the trocar is 10 millimeters, so the aerosolizer is a little smaller than that. So the arm 2 of the study, which is colorectal appendiceal cancer, that has finished accrual. We reported this at the Society of Surgical Oncology meeting, and we're preparing the manuscript for publication right now. And you can see there's 4 appendiceal cancer patients and 8 colorectal patients. So I'm not, yeah. And you can see the PCI, which is the cancer burden, is really high in these patients. And majority of them have had 2 lines of chemotherapy, as I mentioned before. And we select patients so that they can go through the rigor of the clinical trial. So some of the results may be biased because we're selecting patients so that they can actually make it through, we think they can make it through the treatment. We found that it was feasible. So of the 11 patients, 6 completed 3 PIPACs and 7 completed at least 2. The ones that did not complete had progression of disease before the second PIPAC. Dose-limiting toxicities were not seen with this particular regimen, and this is kind of validating the European experience because we were not dose escalating, we're not increasing the dose on the trial, we're keeping the same dose. And we found that the incidence of grade 3 toxicities, which are more severe toxicities, such as abdominal pain and anemia, was very low overall. So majority of patients had minor issues with the PIPAC. This is the efficacy data. So out of the 12 patients, we have now updated analysis, but the slide's a little bit old. So out of the 11 patients, 2 of the patients actually went on to have cytoreductive surgery. And this patients see a lot of different people for second opinion. So this is, decision to proceed with cytoreductive surgery was not, necessarily ours, but that was between the patient and their surgeon. But it seemed like they had seen that surgeon before, and afterwards they had some downstaging, and the surgeon felt comfortable taking that cytoreductive surgery. So half the patients had stable disease on scans, but half the patients did progress. When we look at it laparoscopically, a lot of patients who had stable disease had declining carcinomatosis burden. So that's what the graph is showing over there. So very graphically, in the pink lines, patients who had stable disease actually had declining scores in their cancer burden. So, but on the other hand, the green lines you can tell are progressing, and one person had not measurable radiographic disease that had that little tiny deposits kind of everywhere. This is kind of the swimmer's plot, as we call it. You can kind of see each patient's trajectory. On the x-axis is how long they've lived. At the point of analysis, this is in March, and we are updating the analysis right now, and we have longer-term survival data. But you can kind of see half and half pictures. So half patients actually did well, and the other half, did not do as well. They progressed pretty rapidly. And so, and the overall survival data, again, is early, but for patients in this kind of category, where the third-line chemotherapy is progressing pretty quickly, the survival is measured in a couple of months. And so with that, there is a little bit of an efficacy signal in this refractory setting. So a few things. So one of the things we did in this trial is at each time point, as we were doing the biopsies, those biopsies that make their way into this is called the tissue microarray. So we can put it on a slide, and we can do all sorts of studies now, and we're particularly interested in the tumor microenvironment. And you can look at it in fine detail. You can look at how the tumor is evolving, why they're not responding, if there's an opportunity to enhance the therapy with the immunotherapy. So, this is still very early, so we're looking into that, and hopefully we'll have some clues to improve the next trial design. So this is the trial that is currently open right now, and it's accruing. So this is so after our experience with oxaliplatin, what was disappointing was that even though European centers we had seen this, they had seen clinical benefit. We were not seeing that. And part of it is that we instituted this in a very refractory patient population. And so we wanted to pull this in an earlier line setting. So a lot of patients are already refractory to oxaliplatin by third line setting. They're also have had a lot of chemotherapy. Some of these patients have had 2 years, 3 years of chemotherapy, and their body cannot take any more interventions. And so part of the limitation of the earlier design was even though there was a benefit in half the patients, and we still have to improve on selecting who those half, 50% of the cohort, if we just have not, we would like to see some responses. So one of the challenges that is right now is if somebody is not a candidate for cytoreductive surgery, they will be taking chemotherapy indefinitely, essentially. And so, and this is talking specifically in regards to high-grade appendiceal cancer. And so in that context, can we do something else to downstage their disease so they could become candidates for cytoreductive surgery? So this was the impetus for this particular trial. We also wanted to change the chemotherapy from oxaliplatin to mitomycin C, and mitomycin C is the drug of choice in the U.S. for PIPAC studies, and and there's a long history of efficacy in the peritoneum with mitomycin C that has been reported. So we changed the drug, we moved it into an earlier line setting. So with this trial, patients who have had at least 4 months of chemotherapy, and that has to be standard of care chemotherapy, FOLFOX, FOLFIRI, or FOLFOXIRI, with or without a biologic agent, they would be eligible. But they should not be refractory to iron or TCAM. So that's important because the backbone of this trial is mitomycin C PIPAC, but in between patients are getting FOLFIRI chemotherapy. So one of the challenges with peritoneal disease is that yes, it can cause local problems, but it can also metastasize to other areas. And so FOLFIRI covers all bases. It treats the systemic disease, but it also treats local disease by directly giving chemotherapy. And the weak patients are getting mitomycin C, they're not getting the FOLFIRI treatment. And FOLFIRI is given in different ways. And so we've asked oncologists who partner with us to eliminate or limit the bolus dosing of 5-FU so that it's more tolerable and not as harsh. So obviously this is an aggressive regimen, but the idea is to downstage the disease so patients who are otherwise healthy and want to proceed with cytoreductive surgery and can't because there's a lot of disease, maybe this offers them a chance. There are multiple dose levels on this study, and so this is a dose escalation trial. We don't know what the right dose of mitomycin C to use is in the context of PIPAC, so the goal of the study is to find that dose. And so at each dose level, we accrue 3 patients, and then we move forward once it's considered safe. For reference, IV dose that is acceptable is 10 milligram per meter square, so we're starting at a dose a little bit lower than what has been accepted as an IV dose. But because we're giving directly in the peritoneal cavity, we expect it to be more effective than IV mitomycin C. So it follows the same design of every 6 weeks, and then there's a final optional laparoscopy that is at the discretion of the surgeon who is going to be planning on doing cytoreductive surgery to assess and see if the patient is a candidate for cytoreductive surgery or not. We're obviously looking at efficacy, we're looking at downstaging. There's a multitude of criteria we use to assess that: histologic criteria, laparoscopic criteria, radiographic criteria. And so this trial is ongoing. I don't have results for this. We have accrued dose level 1 already, and dose level 2 is almost accrued. We have wait list for dose level 3, but dose level 4 is still open. So if we have a dose limiting toxicity, sometimes the study stops and expands on that dose level. So there's still, we're still accepting patients for this trial. I want to touch up on a little bit on PIPAC. So this is kind of a slight modification to the PIPAC procedure. With the PIPAC, once we give the aerosol chemotherapy, we wait. So it takes about 5 minutes to fumigate the abdomen. Then we wait 30 minutes for the chemotherapy to precipitate. And it kind of goes in by Brownian motion and by gravity and sits on the surface as the aerosol settles down. And by 30 minutes, majority of aerosol has kind of precipitated. But the electrostatic PIPAC, what it does is it gives a low intensity voltage across the abdominal cavity that immediately precipitates the aerosol. There are some groups in in European countries that are saying that there is advantage to that because with electrostatic force, you can get deeper penetration into the tissues. We're skeptical of those claims. We have to validate them. We haven't seen great data to that effect. So we haven't pushed for this particular strategy. It does reduce the operative time by 30 minutes.
Do you know what the claim is for the depth on the PIPAC?
It's about 25% more penetration.
Okay.
Yeah. There's one group that has modeled the mathematical modeling with that. There's the other claim with that is there's more homogeneous distribution because with PIPAC gravity plays a role, and so with ePIPAC there's more uniform distribution.
Is it fair to think PIPAC has 5 mils depth penetration? That's the number I've always.
Yeah, so the study that was done that measures the depth of penetration, so there's no human study that has been reported yet, but what they've used is an inverted sheep bladder model. So what they do is they take the sheep bladder model, the one side is the peritoneal, so they invert it, so you're facing the peritoneal cavity. And so they've compared, they've used doxorubicin because it's fluorescent. You can look at it under a microscope. So they've compared a HIPAC and a PIPAC model. So in HIPAC, they circulate the doxorubicin as chemotherapy. So what they do is then they cut the sheep bladder and look how deep it has gone. And then they did the same with the PIPAC. It's a static system. It's not a living sheep. So there's no blood flow. There's a lot of considerations there. Sheep bladder is a smaller system. But what they found with that, all the caveats aside, what they found with that is that with a HIPAC, the depth of penetration is 2 millimeters. With PIPAC, it's about 5 millimeters. So there is increase. So with the ePIPAC, at least the mathematical modeling would say that it's 25% more than the 5 millimeters.
What's PRGS?
Is there one more question?
What's PRGS?
Yes, so PRGS is a criteria pathologists use to document if there has been a regression or not. It stands for Peritoneal Regression Grading Scoring. And this is born out of the necessity of PIPAC. Before that, we didn't care as much. There was a response criteria for tumors in the peritoneum. However, because of the PIPAC, we need to know if the tumors are responding. So PRGS was developed at University of Tübingen, where the PIPAC was developed as well. And in the process, what they've learned is that pathologists can agree on what the PRGS is. What we don't know is if somebody has a decrease in PRGS, doesn't mean they're going to live longer. Okay, so in the ARM2 data that we've looked at it, that's not the case. PRGS does not predict survival. So we don't know what the actual utility of histologic response criteria is. Many people who come into the trial have chemotherapy, and they already have some elements of response in their tumors. We know the chemotherapy hits the tumors differently. In one area it will cause shrinkage, in another area it doesn't cause shrinkage. So when the pathologists look at it, they call response even in patients who've not had PIPAC yet because of their prior treatment. And then if it decreases a little bit by one score, it's an ordinal scale, so there's ranks, there's 5 ranks. So if it goes from rank 4 to rank 3, does that mean the patient really responded or not? And so our analysis at least demonstrates it's not as good a tool. What does predict survival, so far what I can say is that radiographic response does not lie. So if you have a response on CT scan, or if you have progression on CT scan, that tells you that a patient's going to live longer or not. So this is still in development, the story is still in development. But, we'll share more of that in the future. I'll stop here, and I have other slides on what gets me excited from a science standpoint. I'm happy to chat with anyone about that. And so there's a lot of things coming. Actually, 2 days ago from UCSD, Dr. Lowy published this really nice paper on thin slice preps from, they take the tumor, and Joe can tell me because he's one of the authors on the paper. But what they're doing is they're taking thin slices and growing them in the lab. They can keep them alive for 7 days, and that's a really good model. Because we don't have great mouse models, for example, for this disease. And so for 7 days, you can kind of assess drug toxicity and things like that. So that's really exciting. So that just came out like 2-3 days ago. Yes.
What are the exclusionary criteria for the PIPAC?
I'm sorry?
What are the exclusionary criteria for the
Yeah. So if patients have extra-peritoneal disease, for the purposes of the trial, we've excluded those patients because where the extra-peritoneal disease is and the burden of it is really hard to objectively measure. Even though we can say there's 1 nodule, 2 nodules, 3 nodules, or 1 organ involved, 2 organs involved, it's really hard to keep the patient population homogeneous to make a reliable conclusion. And so that's the reason for exclusion right now. There are European centers, especially at National University of Singapore, they've done patients who've had liver or lung metastases, and they've combined the bimodal therapy, which is the IV chemo and the PIPAC. And I think that could be a thing to do in the future. I think for now, for the purposes of the trial, we've excluded those patients who have extra-peritoneal disease. We've also excluded patients because FOLFIRI is the backbone, so if somebody has been refractory, meaning their cancer has gotten worse on irinotecan chemotherapy, we have excluded those patients. The other exclusion criteria is if somebody has bowel obstruction, they're TPN dependent. Generally, that signals a very aggressive process, especially with high-grade cancers. And usually, we've learned from our earlier trial is that patients don't make it to the second PIPAC. They can only tolerate 1 PIPAC, so they don't get to reap the benefit of the treatment. So those patients are also excluded. I think those are the main ones, but there's more detailed ones that are on the NCP website. Yes.
If a patient had 2 HIPACs already, or MED now, and if you do have a reoccurrence, can you be a candidate for PIPAC?
Yeah, that's a great question. There's nothing in the exclusion criteria that says that they would be excluded if they've had prior HIPAC. However, with HIPAC, it depends on how much cytoreduction was done, how much surgery was done. Every surgery that takes off the peritoneum will cause some scar tissue to form. And if you have a lot of scar tissue forming, there's not enough space to fumigate the abdomen. And so that causes limitations. So what we've asked is folks who are, our colleagues that are referring patients to us, especially the patients who've had prior HIPAC or cytoreductive surgery, we would ask them to get a laparoscopy locally with their surgeon before they make arrangements to travel and come to us, so that they can at least establish that there's room in the abdomen to do the PIPAC treatment.
This Northwell is LIJ. I work for Northwell. Is it?
Yes. Dr. Larry Whalen is the site PI. You may know him.
Thank you.
Yes.
What are the adverse events that happen with
Yeah.
HIPAC?
Let me go back to this slide. So grade 1 means, very mild. Most of it can be managed at home. It is a deviation, it's a nuisance to have that side effect, but it's not something that you would kind of go to the hospital for. It's something that can be managed with medications. Grade 2 is a little bit more intense, so severity is a little bit high, but still not to the extent that it would be significantly obtrusive to tolerable pain. Grade 3 is more serious, where you would call your doctor and say, I need to come in, And so you can see that majority of side effects are related to electrolyte derangements or, nausea, vomiting, constipation, fatigue. Those are some of the GI symptoms. So the way we grade, it's not possible to know exactly if this is attributable to the treatment, because you can see nausea, vomiting, fatigue can be all part of the disease process itself. So the way the investigators, assign it is we say definite, possible, are probable. And so, in fact, I know that because, I assign a lot of these. None of these are definite PIPAC related. We kind of generously grade them and say probably related or possibly related, but we can't rule out the possibility that they could be conceivably related to the treatment. There's one kind of unique side effect that was seen by the Singapore surgeons, where they reported 20% incidence of pancreatitis with this oxaliplatin PIPAC. We did not see that in our cohort. So, there could be some racial ethnic differences in that. I think it needs to be further explored. It was not seen in European centers either. So I'm not sure, what that means, but there's not a unique set of unique complication ascribed to PIPAC. There are, however, surgical complications with any procedure, with any laparoscopy. So patients who have a lot of cancer burden, laparoscopy is not minor. You can injure the bowel, you can perforate the bowel, and so those are real risks. In our study, we were very careful. We use ultrasound to figure out where to place the ports. But despite all of that, you can have an injury. And especially if the injury is not recognized and you do the chemotherapy, your immune system is down, it can potentially be catastrophic. There have been 1 or 2 deaths reported in the worldwide community from the PIPAC procedure, and that is more than 8,000 procedures. So it is very rare that something like that can happen. Drug reactions can happen. Oxaliplatin is a platinum agent. Platinum chemotherapy can cause an anaphylactic reaction. 1 in 400 people will have an anaphylactic reaction to platinum. And we prepare our team when we teach the PIPAC course. One of the elements we teach them is how do you respond to an anaphylactic shock when everybody's out of the room and the oxaliplatin is being given. That's why the anesthesiologist was wearing the pepper, ready to go in. Arguably, the safest place to have an anaphylactic shock is in the operating room when you have a breathing tube already in place. But still, there are medications and blood pressure support that needs to be given at that moment. We don't recommend any sort of resection along with PIPAC. A lot of folks ask what is the difference between HIPAC and PIPAC. So usually HIPAC is given to kind of treat the microscopic disease. Not always, but in general, that's the most predominant use of HIPAC, where all the disease is cleared and there's 1 or 2 millimeter disease that is remaining, or microscopic disease that is remaining, and you do the HIPAC. With PIPAC, initial studies that combined side reduction with PIPAC were met with really high morbidity. And that is probably because there's more drug penetration with PIPAC, and hence there is maybe better efficacy, but also more toxicity from that. So a lot of leakages from the anastomosis and such that it's not recommended to do cytoreductive surgery right now. There is a newer trial that is coming out that looks at specific stomach surgery in the context of PIPAC, saying that it's safe if you follow certain parameters. But as of now, it is only in situations where you can't do surgery. Yes.
Yeah, so I think, Dr. Raoof, this was so fascinating, and it gives us such hope